and gets trapped over the kidney or something.
Oh, yeah.
Nephrosplenic entrapment. Yeah, I had one that I was pretty sure I did a gastropexeon, and then like a bowel loop like went over the pylorus or something. That's, I don't know, something weird like that.
Get it phenylephrine and put it on the lunge line.
Oh yeah.
Great.
Try and bounce it out.
Okay. All right. Thanks, guys. So let me get this party started here. We had fun conversations in the Pyometra talk. Okay. So we're going to talk about GDV here. The proceedings that hopefully you have, and if not, I can send them to you if you want them, will be very, very detailed. They are the most up-to-date medical literature thus far. And so this talk is intended to be practical, clinical, usable information. The proceedings are going to be insane minutia, details, mostly like academic. But if you want that level of detail, that's where it is. And again, my contact information will be at the end of the talk. You're welcome to message me, and I'm happy to send it to you directly if you can't get it from the conference. But this is meant to be a practical discussion. Open discussion as well. Any questions, comments, disagree with something, please vocalize your inquiry, and we'll talk about it. So it's fairly informal. So I'm Dr. Shadia Rafij. I graduated from Cornell University in 2006. 1-year general internship at Angel in Boston. I did 2 surgical internships at Long Island Veterinary Specialist, followed by my residency there, and then I moved out west, Las Vegas, practiced there for a bit, then did some traveling, surgery work, and then I settled in Silicon Valley for a year, managing 3 hospitals, on call 24/7 between all 3 of them for surgeries. Then I moved to LA and converted an overnight facility to a multi-specialty hospital. I managed internal medicine, surgery, and oncology in LA for about a year and a half. And then currently I operate Vet Triage, which is a 24/7 video telehealth platform. We partner with clinics to help with triage both during and after hours. So if you're interested in talking about more telehealth stuff, please go ahead and ask or meet with me afterwards, and I'm happy to go over the world of telehealth with you. GDV. We're going to go through all of these different bullet points here, and some of the stuff, of course, is going to be quite basic. How many folks here do cut GDVs? Okay, yeah, a fair amount. It's fairly common, between 2.4 to 7.6 for every 1,000 dogs admitted to the hospital. There might be a slight predilection towards males. They tend to be middle to older age dogs, and of course, you know, since they tend to be large breed dogs, this is borderline geriatric, depending on the breed. They're a large breed. German Shepherd 12%, Great Dane 11%, Standard Poodle 5%. There's a ton of breeds predisposed to this, and of course, it can happen in non-large breed dogs as well. I've seen it as well. We'll talk about that too. I have suspicions about that, and I want to say there was like 1 or 2 cat reports of GDV. I want to say, but dogs, of course, large breed, deep-chested. Risk factors, there's a way more than this, but these are just the ones that I thought were like, oh, these kind of matter, and the rest of them are maybe more of associations, not really causality. But older patients, large breed dogs, feeding them low number of meals per day, their temperament, mostly like an anxious or neurotic temperament, is predisposed them to GDV. They have a familial history of it. They have a history of splenic torsion, history of splenectomy, 3 to 8% rather incidence, puts them at 5.3 times risk. A history of a gastric foreign body or a current gastric foreign body, 5 times risk, and then being intact. But again, how much of these actually really matter? I do believe a lot of us will follow this route. That having splenectomy may predispose them, but I don't know about these other things how vital they are. But I want to at least bring your attention to some of the risk factors out there. At the end of the day, it doesn't really change what you do with these cases, but it's more just for knowledge base and for client communication. Of course, despite how common this is, we don't really know the etiology, right? Like, does the stomach dilate first, then torus, or is it torus first, then dilate? You know, chicken and the egg, we don't know. But so you have a bloat and a volvulus together. Just gastric bloat on its own is not, technically speaking, a surgical emergency. So usually you have to have the volvulus as well. Most of course, are acute, but I do put here chronic. I've seen some dogs that I'm convinced are I call them chronic bloaters, where if you probe the client enough, you find out that dog had an intermittent history of GI compromise or whatever, and then it resolved. And I believe the dogs that are like this have a history of that, but also they come in completely stable. Big abdomen, GDV, walking around, and the owner came in just for distended abdomen. No vomiting, no drooling, no retching. And then my third sort of clue at this is I'm in surgery, and as I'm trying to gastropexy, the stomach is actively trying to torse on me while I'm in surgery. And I can also notice that the small intestines are hyperperistaltic. Everything's energetic in here. And I thought, boy, maybe this dog has always had a history of this and it kind of self-corrects. So these are my theories. There's nothing in the literature about chronic as far as I know, but I believe that there are at least a small subset of dogs that have chronic GDB. So don't ever discount a very stable dog coming in with distended abdomen. Don't ever discount GDB. Still go through your differentials, but I'm convinced that there's something going on there. I'm also convinced that even though we consider these animals to be primarily idiopathic, I'm convinced there's got to be a primary condition, and my suspicion for that comes from cases like, for example, I have a GDV that also has laryngeal paralysis, and it's coming in with respiratory distress and a GDV. And I thought, boy, maybe it's sucking so much air, it tores, so that may be the predisposing factor. I've had dogs that have had lung tumors. I've had dogs with liver tumors. And my thought always is, are these diseases affecting either the digestive functionality of the patient or their ability to breathe normally, predisposing them to a GDV? Do they have underlying Helicobacter, inflammatory bowel disease? So I'm convinced there's primary causes. We tend not to look as much because these tend to be older dogs and it's an emergency, and if your surgeon on call is in the middle of the night and you're not working up stuff, you're trying to save a life, So it makes sense that we don't really go down this road, but I really wonder how many of these animals actually have a primary condition that you can argue predispose them to having the GDB. So my main point with this really is, if you have the ability to work them up, either preoperatively or postoperatively when everybody's back in the building and the dog's recovering, then do. If the pet owner wants to work stuff up, then go for it. And I would say my ideal diagnostics would be blood work, urine test, 3-view thoracic radiographs, abdominal radiographs, and abdominal ultrasound, and we're trying to just find anything that could have predisposed them. And also, when you intubate them, do a thorough oral laryngeal exam. Look for any tonsillar masses or epiglottic issues or whatever else while you're intubating them, because you want to look for anything that can predispose them. But again, this is my suspicion. We typically consider them idiopathic. Lactate concentrations, this is more academic, it's in the proceedings, and then average rotation is 180 to 270 degrees. So the pathogenesis for this is, of course, multifaceted, it's complex, it is a systemic disease. Despite the fact that it is the stomach that we're focusing on, there's like any other intense condition, like hemoabdomens, pyometra, it's gonna affect the whole body. And this list is pretty much the flow of it. It starts off with hypertension, probably as a component of compensatory shock, and then the caudal vena cava gets compressed. Then with loss of blood flow, the intestines are compromised, so you see bacteremia in 40% of these dogs. Then the portal vein is compromised, which compromises the liver, more bacteremia. Pancreas gets roped into the stomach because of its anatomy, and then stomach compromised 10 to 37%, so meaning like necrosis of the stomach. The spleen can get involved, it can rupture, or the vessels rupture, or the spleen itself can rupture. And you have a hemoabdomen with these dogs, and then end stage is going to be, of course, coronary flow is affected. In 40 to 70% of the cases, you're going to see an arrhythmia. And so this is just to keep in mind that these dogs have multiple things going on depending on their own biology and when you're catching them in their GDV path. We all know this, clinical signs, so distended abdomen, non-productive retching, nausea. So stabilization. Fluids, of course, are going to be the main goals here. I've always done it, and maybe criticalists have a different idea now with like low volume resuscitation. 2 large bore catheters, start pouring in the fluids as fast as you can. These are large breed dogs, they're going to take a lot of fluids, and you're trying to stabilize their hemodynamics, their cardiovascular system. And then while you're doing this, the question is, gastric decompression, when do you do that? So how many folks trocarize in preparation for surgery? Yeah. How many folks don't trocarize and they wait to get into the OR or at least have them on anesthesia and then pass over a gastric tube first? Yeah. I'm the orogastric tube category, mainly because I'm trying to get them in the OR. I have a whole surgical team, so we can move pretty quickly. I can see that if you need time to get the surgery aspect set up, that this is definitely a viable. I know there's at least one study showing that this actually does work.
For me, I'm doing the orogastric decompression literally on the way to the OR. And a lot of times I have the abdomen open as my tech is pushing down the tube. By pushing down the tube, it helps me actually detour the stomach. Because sometimes you have those ones where you're trying to detour them and it's just like locked into place. The distal esophagus is so tight. If by counter pressure, this is what I hypothesize, from the orogastric tube from my technician, they put pressure and I can sort of use that to leverage, and then together they're entering the esophagus, they're entering the distal esophageal sphincter, and I can now detour them easily. So try that if you are stuck in a bind like that. That seems to work really well, at least in my experience with it. But yeah, I'm just going to go ahead and now if there's some reason why we're waiting on the client's finances, they have to sign the paperwork or whatever, then usually the ER department is going to chokerize for me, or sedate the patient and then pass a tube, whatever is needed. And then in terms of colloids, so my general rule, and again, this may be different than ER doctors' rules, is if they have hypotension and I'm going to bolus them fluids, I'm going to bolus them, and I'm going to remeasure the blood pressure. If the blood pressure still is not good after the bolus is done, I'm going to probably repeat another bolus or two. If I'm still not happy with blood pressure, I'm going to add in a colloid. Usually I'm doing hetastarch. My general rule is if I bolus hetastarch, I'm going to continue it on a CRI. That patient automatically now gets hetastarch CRI until further notice. And so hopefully you bolus in the hetastarch, now you see the blood pressure going up, and then I calculate a CRI, now they're on fluids and colloids. That's my general rule. It's worked very well. Whenever I've seen hetastarch or another colloid bolused and then not continued onwards, the blood pressure tanks again. And so they need that support, is that's my 2 cents with that. Of course, everybody has their own way of trying to stabilize these depending on your experience and what you have available in your facility. So this is examples of gastric decompression and gastric lavage. If you're going to gastric lavage, I don't always do that, but you could. Sometimes we're doing it just because I'm pexying and my technician just wants to get more of the food out of the stomach. Great, we'll lavage, but I don't know how necessary it is, but I'm sure it helps make the pet feel better. This is showing pre-measuring the tube. The idea behind this is that you don't perforate the stomach. Now, my thought on this, we measured, of course, because it's easy to do and it's quick, but you could be off, obviously. Like this looks like it's really caudal, but I don't know. But the point is that if you penetrate the stomach, it's probably a necrosed area. And I'm not saying you want to penetrate the stomach, we're not advocating for that, but if it does happen inadvertently, don't feel bad. It needs to be resected anyway. So if this is a matter of saving a dog's life and you didn't have time to measure it or don't have assistance to help you with the decompression, decompress the damn dog and move on to the OR when you can. So that's just a tip there. It's kind of like blocked cats. If you penetrate the urinary bladder, is there a good chance that it's actually not you? The bladder was friable to begin with because of the obstruction. So, don't feel too bad if it happens. I've only had it happen on one dog, and it was in a necrosed area of a stomach and a Great Dane. And then some dogs are so messed up from shock that you can pass a tube without any sedatives. They're obtundant / borderline comatose from the GDB. That you can open their mouth, put a medical tape in there to help protect yourself and help them prevent biting the tube, and then pass the tube that way as well. Because in these cases you're scared of giving them any sedation or anesthesia because they're already critical, and so you don't want to tip them over the edge to where now they're gonna die from it. So you could potentially do it while this is for dogs that are like obtundant, like they're barely arousable. Is not the ideal. Ideally, you want to sedate them and have control over the airway and everything. And then there's surgery, of course. So you can see something like this, of course. That's terrifying. That's the gastric necrosis area. Usually this area is going to feel like leather. You're not going to palpate any vessels. Of course, it's discolored, and so that's awful. And a lot of times these are over by the cardiac area here. It's a lot of times it's behind the stomach, behind this area. So you have to really look underneath the stomach and see. If I just see erythema there, of course I'm not going to resect that. I assume the erythema will get better. If it looks like this, sort of purplish, maybe not necessarily black, but it's like kind of purple, dark, I'm going to leave it alone and proceed with the gastropexy and then go back and reevaluate it and see if it's through detorsion that the vascular supply improved, and now maybe I don't have to resect the area, because We all know the resection sucks, and it also adds considerably to morbidity and mortality with these dogs. Most of them don't make it, as far as I'm concerned, with gastric resection. And I'm not sure I see much of a difference between resection and involution. But the involution part, I don't do because you know how these cases scare you. So we had a surgeon that did it, went great, dog did well, came back like 2 days later for pyloric obstruction from the sloughed stomach. It's like, come on, you know, yes?
I've never heard of an involution.
Yeah, the idea is instead of resecting it like you're doing here, you basically invert the healthy edges, and then as that part dies off, it'll go into the stomach and they'll digest it.
Oh.
Yeah. That's the idea there. So it sounds great in theory. It's definitely easier surgery than resecting, but that one case scared me. It's like, okay, you know what? I'm not doing that. If I have to, I'm going to resect. I also know surgeons and GPs that cut a lot of these, where if they see gastric necrosis, they'll do the pexy, they'll leave us alone, wake them up, 2 days later, reoperate, and see if they still have to. That's how crappy it is to remove these. How many folks here have done gastric resections? Yeah. Lucky, good. Yeah, so I even know surgeons that will recut the case a day or two later to reevaluate the stomach and see if it needs to be resected. Which, you know, fair enough. I mean, if that saves the resection and, you know, helps the dog improve, sure, it's definitely a novel way of doing it. But I'm going to pretty much make a decision right then and there. I've warned the owners preemptively that if I have to remove the stomach or remove a portion of the stomach, that I'm going to, and, you know, c'est la vie. There are many different types of gastropexies, of course, and in the proceedings it has what the strengths of all these are and all that. Obviously, most of us are going to be doing the incisional gastropexy. This is just to remind you that, you know, laparoscopic exists. Obviously, you're not going to use laparoscopy on a GDV, right? Those are going to be open procedures. But for prophylactic gastropexies, you can, you know, attach the stomach to the abdominal wall and you get this nice-looking pexy. So at the same time as like the spay, you know, you can offer this if you have that. The surgeons in town like to do this, so it's just a nice reminder. There are many different variations of this with using scoping, but most of us are going to do the incisional gastropexy. So the idea here is to create an incision in the abdominal wall, and a matching incision in the first layer of the stomach. You don't have to go full thickness, just partial thickness, and you're going to have these two meet up. So the adhesion length you're looking for is somewhere between 2.5 to 5 centimeters. You want to be located, this is kind of dumb, and this is in the textbooks, but you know, obviously it depends on the size of the dog, how many centimeters oral to the pylorus you want to be. So you're just going to use common sense. You don't want to go over the pylorus itself or the pyloric outflow tract. You want to stay on the actual stomach. And typically about an hour surgery. Definitely could be faster than this, of course. I've done them faster than that. And what you're looking for here is to oppose stomach wall to abdominal wall. You're going to suture the deep end first, right? Because that's where you have easiest visualization, and then you can suture the superficial. If you start with superficial and then try to go deep, you're now fighting your own repair to visualize it adequately, and you're going for this. So a couple of pointers here. Number one, if you're using Balfour retractors, retracting the abdomen, right? You retract the abdomen, detours the stomach, you're doing your Explorer, now I'm going to pexy, remove the Balfours, because the Balfours are just going to fight your tension, and it's not really anatomically correct. The Balfours are stretching out the abdominal cavity. So remove them, and then from there, I'll place, if I'm by myself, like in the middle of the night, I don't have like an intern or resident with me, I put a towel clamp on either side of the abdominal wall, usually the side of the pylorus where I'm standing, and I'll hold the abdominal wall up, and I'm suturing the pexy with the other hand. And that's a nice way of avoiding having an assistant. Obviously, ideally, I have an assistant there who can help move organs out of the way, and I can do my thing. The assistant would try to like give you enough room so you can work and whatever. But I'll use a towel clamp technique in surgery. Yes?
Do you worry about entrapment? I'm always kind of worried about bowel being entrapped dorsal to the pexy.
Yeah, so the question is, are you worried about bowel entrapment dorsal to the pexy? And I had one dog that I suspect that happened to, that I had to reoperate again, because the radiographs looked like a small intestinal obstruction, and even the gas pattern, the gas of that loop was cranial to the stomach, which doesn't make any sense. And so I'm convinced that was the case there. But otherwise, no, I don't worry about it. I've only seen that once in 18, 19 years of doing it. But no, has anybody else ever seen that before? It is reported. It is a reported complication, but very, very rare, I think. Yeah. And honestly, I wouldn't even know how you would necessarily prevent that. I don't know what you would do for that either. Anyway, it seems to me just kind of bad luck, and we have to deal with it. But I don't know what you would do. Maybe you try to aim your gastropexy as cranial in the abdomen as possible. Maybe that's a solution. But the more cranial you get, of course, you're closer you're getting to the rib cage, and you can cause pneumothorax. So you want to stay caudal to the ribs. And then when you're doing this, when you're making your incision here, practice it first. So take the stomach and just push it over to where it can contact the abdominal wall. You want to avoid the ribs, and you also want to avoid excessive tension with your pexy. So take the stomach and kind of make it, for lack of a better term, have it kiss the abdominal wall, and then you're like, okay, this is a pretty good spot here, and so I'm mentally remembering that, and then let go of the stomach, make the abdominal cut, reposition the stomach again. No, it looks pretty good. Then make the stomach cut, and then towel clamp, and start suturing away, or have your assistant in there to help. This is what you're looking for. Complications. Overall complication rate, 76%. Acute renal injury, 3 to 8%. Disseminated intravascular coagulopathy, 8%. Arrhythmias, 30 to 50%. Splenic thrombosis. These are all the same complications, not necessarily prevalence, but any severely hemodynamically compromised patient is going to have risks of these things happening. These are things I warn pet owners about, whether it's a PIO or a hemoabdomen or a GDB. I'm warning them about these things. Peritonitis and recurrence. Recurrence is typically very low. I tell pet owners the recurrence rate is probably going to be higher for those dogs that we know have comorbidities that are prone to not healing well, maybe diabetes, Cushing's, hypothyroid, cancer, whatever. Otherwise, I expect them to not recur with this. Now, as far as cardiac arrhythmias, this is of course a concern. You can see cardiac arrhythmias pre-op, intra-op, or post-op. There's many reasons why we think it happens, and usually it's going to be like a VPC, but other arrhythmias are possible as well. This is ventricular tachycardia here. And so what do you do? So my protocol for this, and again, people might have different opinions on it, which I welcome, is I'm going to try and stabilize them with, well, first off, do I have to treat it or not? And I have two parameters for that. Number one, is the patient clinical for it? Are they weak? Do they have pale mucous membranes, drop pulses, increased respiratory rate, signs of poor cardiovascular function? And the second is, am I seeing 25 to 30% or more of the ECG strip comprised of VPCs? And if one or both those parameters are there, then I say, okay, I'm going to treat these. If it's less than 25% ECG and or they're not clinical for it, then I'm probably going to monitor. And by monitor, I mean I'm going to do an ECG either every 6 hours or ideally continuous. Because you can spot check them, but you can definitely miss them, right? A continuous ECG, if you have that ability, allows you to continuously monitor them. So if I believe that it's worth treating, then I usually am going to start with a bolus of lidocaine. I don't have doses offhand, but a bolus of lidocaine, and hopefully that'll convert them, and then a CRI of lidocaine. And then now they're on the CRI until we see that the arrhythmias are dissipating effectively. The problem with lidocaine, of course, is it can cause ileus and nausea. They don't want to eat, and of course that's usually you want them to eat before they go home. And it can cause neuromuscular weakness as well. And usually these are older dogs. They have arthritis. They're decrepit and stiff, and so now they're weak because of the lidocaine. So obviously you want to treat the arrhythmia because that can be life-threatening. But just be aware that you want to get them off lidocaine as soon as you can. I was always taught by the internist, and maybe this is incorrect, but that you don't have to wean them off. You can stop cold turkey. I still wean them off because it's hard to just stop things. But you're permitted, I believe, that you can just stop it. Now at the same time, if I'm going to start them on lidocaine, I'm starting them on procainamide automatically. They're automatically going to get it. It's going to be IM initially, I think QID, I want to say, and then once they start eating, they're going to get oral. And so that's again the internists that I worked with. That's what they would recommend doing with them. I have not given this IV as I don't know if you can or what, but I haven't. I know there are other drugs that you can give injectable to help with problems like this. But again, this is how I was taught, which is not a great reason, but that's how I was taught, is procainamide. I will start that at the same time that I'm starting lidocaine. Because I'm going to send them home with procainamide. They're going to go home with it. Because I can't check their ECG at home. And I want them to come back in 2 weeks for a recheck to remove the stitches or staples or whatever. I'm going to check another ECG when they come back. Now, is it accurate? No, of course not, because there's 2 weeks where you didn't measure their ECG, and now you can do it for a 1-minute strip during an exam. But it's better than nothing, because I don't know realistically what else to do other than like a Holter monitor, which you could do, and that would be the right way of doing it. Have a Holter and go, but I've never done it, you know? I know that's the ideal, but I don't have one, and all that. So just be aware of these things. That's the point is do the best you can, considering that. Just realize all these things. Bronchopneumonia, remember these are going to be like pretty sedentary dogs. They're old or arthritic, they're not going to get up right away. You got to get them moving. You got to get them moving to some degree, because otherwise they lay there, they already had a history of regurg or vomiting, and they're nauseous. They're on lidocaine and just had gastric surgery. So, you know, things like bronchopneumonia, we want to be diligent about trying to prevent for these old dogs. Also, another thing too with old dogs is you know, again, they are arthritic. So when you tie them on the table in the OR, loosey-goosey with the legs. I've had too many dogs where they wake up and they look T3, L3. They can't freaking walk because they were tied too tight on the table. A young dog wouldn't matter, but an older dog, they're arthritic, and so be aware of that. You don't need them tight on the table. Just loose, you know, wherever they naturally lay, and then just tie it in just as a precaution, but don't crank down on their limbs. Just a little advice there. Mortality. Incidence of 10 to 68%, survival pretty high, no surgery, of course, they don't do well. Presentation will affect the prognosis, so if they present to you obtundant or comatose, there's a larger risk of problems. Splenectomy does increase the chances of having issues. Gastric necrosis is massive, over 50% mortality, puts them at 6 to 11 times risk. Lactate concentrations play a role, various biomarkers. These are in your proceedings. It's all blood values, but this is these are our mortality factors. And then post-op care, monitoring, we talked about some of these. This would be like my treatment sheet, you know, afterwards for these cases. They're gonna have ECGs, ideally continuous. You're gonna TPR them, whatever makes sense, and depending on your staff. You're gonna weigh them ideally, you wanna know what their fluids are doing. Respiratory watch, regurgitation watch, walk them, get their stiff joints moving. E-collar to prevent licking, of course, the incision, and then blood pressure. You're going to check it again. I'm going to check it, if not continuous, QID, and after you're bolusing them with fluids or colloids, you're going to check the blood pressure. So these are your basic parameters. And then depending on the patient, if they had any abnormalities, you know, you can recheck those things too. If it came in asymptomatic, maybe a day or two after surgery, recheck the blood work. If it came in with low blood glucose or something like that, you know, these are just spot checks that depend on the case. You want a minimum database, of course, pre-op, but if there are derangements, you want to follow up with them. This is obviously not a GDV, it's a random plug from the internet. I just wanted to show all the tubes and things that can go into these dogs. You know, 'cause you're talking about continuous ECG, continuous blood pressure, they're on IV fluids, they're on colloids, and so they have all this crap on them, and so this poor dog is hooked up. This might be a GDV. That's possible. So medications. You know, antibiotic use. I mean, the main reason why I'm going to use antibiotics for these dogs is the bacteremia part of it. You know, you have vascular compromise to the intestines and liver, so theoretically they're at some low grade of sepsis or SIRS, and I'm going to have them covered. So usually cefazolin perioperatively, and then until they're eating, and then once they're starting to eat, they're on cephalexin. How many folks here use antibiotics for GDVs? Yeah. Anything different than cephalexin? If I do think they truly are septic, then I may go broad spectrum with unison flagyl, unison batril, and then get them started on orals once they're able to eat. Otherwise, yeah, it's going to be cefazolin and cephalexin. They're on IV fluids at whatever rates appropriate, pending their blood pressure and hydration status on physical exam. Colloids depending on blood pressure and if they have low protein or not. Procainamide, lidocaine we talked about. You want to have antacids, you want to have anti-nausea, analgesia, of course, and then any sort of concurrent medications for comorbidities. Be realistic about it. Obviously, if the dog's on thyroxine and what is that, denamarin and all this other crap, you know, remember they just got out of surgery and these are all oral drugs, so just keep that in mind. But you also don't want to forget about these things either. And then, of course, any metabolic derangements, again, you want to treat for, depending on what you find on blood work. Maybe they're low-grade coagulopathic, or they have low albumin, they need an albumin transfusion, whatever it is that you're seeing. So a couple of key points here. Ideally, it's prevention, so you want to do the prophylactic gastropexy, of course, right? That's great. Of course, I did mention chronic, but keep in mind, these are primarily acute or para-acute cases. Are they truly idiopathic, or is there a primary cause? You know, so don't be afraid to look for that, either preoperatively, or if you don't have that luxury, then post-op, the client wants to work things up, try and see if there's other reasons why the dog had a GDB. Towel clamp technique we talked about. If you don't have an assistant, Delaying gastric resection we talked about, whether it's in real time or whether it's like 2 days later or something like that. It's up for grabs, I don't know. But most of us will at least wait in the surgery, finish the procedure, and then look again at the stomach. Splenic and hepatic biopsies. So these are the same dogs that are at risk for GDV, of course, are at risk for hemangiosarcoma and other things. And so, and again, I'm always looking for primary causes of GDV. So if I'm removing the spleen, I want to biopsy it. I'm going to submit it for a biopsy. This is, of course, pending owner approval, but I pretty much make it like, it's not negotiable. I'm submitting the biopsy, I'm submitting it. Hepatic biopsy, it's purely a neoplastic screening tool. It's, again, just how I was taught. There's no literature behind it, but if a pet owner is willing and able to pay for this, I would love to get a hepatic biopsy. It takes a second to collect the biopsy, I can submit it, and then I'm good to go. As an intern, they would scare me and say, I had this one case one time, I diagnosed hemangio from a liver, and, from a GDV. I don't know. But anyway, if I'm removing the spleen, though, I would like to biopsy it. Of course, if you see a hepatic mass or something, you want to remove that as well, or at least biopsy it or whatever. But anyway, so keep those things in mind. Not hardcore requirements, but I tend to push them if they're able to. And then this is always a fun one, concurrent surgical procedures. Hey, by the way, while you're in there, can you do his teeth, or can you, remove the bladder stones or whatever, right? And you're trying to save a life. And so this is going to happen, and usually it's financially motivated. It's cheaper to do it all at one time and not do it later. But some of it is for the benefit of the dog. You want to have minimized repeated anesthetic episodes. So my conversation with this is, yes, if and only if the patient is doing well under anesthesia and I feel safe. Otherwise, I reserve the right to abort mission. I'm not going to do the bladder stones, the mammary gland tumor, or whatever if a dog is not doing well. The goal is to save a life. I know it's going to cost you more later on, more anesthesia, but I'd rather have an alive dog, right? And so they will, at least verbally, if not in writing, verbally say, sure, use your discretion, doc, whatever you think, right? So that's how I tackle those. Yes?
Not to interrupt you, but
Please.
What's the consensus on doing prophylactic gastropexins in the younger dogs?
Yeah, what's the consensus on that? So I would say overall, there's still a strong push for that. Now, if you're doing it laparoscopically, that's great. Less morbidity for the patient, rather post-op pain related to that. But if you're doing a spay and you're already in there, then I'm a fan of it. I think it's still strongly encouraged. Do folks here perform prophylactic? Yeah. Do you have a concern about it, or is you just?
We were using a boarded surgeon, local surgeon, and she said she doesn't recommend it.
I've heard the same thing. I was gonna ask the same
Yeah.
question.
Do we know why? Why is there a trend for this? As far as I know, we're still pushing. I have plenty of friends in GP that offer it, and I don't know where I stand on. Let's say it's a hemoabdomen. I'm doing a splenectomy. Do you PEC that dog at the same time? Because we know that splenectomy can be potentially a risk factor for GDV later on, and it's usually a large breed, deep-chested dog. They're prone to it, but also you might be removing hemangiosarcoma, and we probably have all had cases that come back with a GDV 2-3 months after a splenectomy. And so those are ones where I'm like, I don't know. I don't know what to do with that, because if you have a hemodynamically unstable patient, I want to treat it like the last point here. I want to abort mission. I want to save the life, PECing later, But some surgeons feel very strongly about PECing at the same time. Others, like myself, I prefer not to, but I can be convinced. But yeah, I'm curious as to why the trend is for that. Yes?
Maybe she's read some studies.
Yeah, I didn't see anything, but I'm going to have to look now, because I didn't hear about this.
I've just had clients tell me, that's the only thing I got, that after their dog was PEC'd, they vomited and or regurged more, and so they wish they hadn't done it. That was them. I don't know if that's made it out into the world, maybe.
Okay. Yeah, I'd have to ask around more and see if there's any literature on that. Thank you for bringing it up. I haven't heard that myself. Yeah. That's how I handle concurrent surgical procedures. I'm allowed to abort mission if I deem it unsafe for the patient. And this was just to go over the towel clamp technique, which we already did, if you need help. That's it. This is my contact information. Feel free to email me or follow on social or whatever you want to do. If you want the proceedings and you don't get them from the conference, reach out to me. If you want to talk about telehealth and partnership with Vet Triage, happy to talk about that. Do you have any questions, comments, concerns?
Can I show you a picture?
Yes.
I want to show you a picture of this.
You have radiograph?
wish I could project it, you know.
I know.
as well. Wow, I don't know if you guys can see that, obviously it's small.
Into the,
So GDB, and then it went through the diaphragm.
yeah, and he was apparently like very sick for like a few days, and they were having trouble getting into ER. And then when they came in, ER, like he was very lateral, tended, he was like depressed and everything, and he was X-ray, and he was I've never seen that in my life.
Yeah.
What the hell is that?
How old?
A
You
year
know,
old.
a year old.
A year old golden
See?
So one of the indications for going into like emergency surgery for like a diaphragmatic hernia, congenital or traumatic, either way, is that if the stomach herniates through, then it does get prone to at least bloat, if not GDB. I've never seen a GDB before with a diaphragmatic hernia, but I'm going to assume that the primary cause here, yeah, he was born with a hernia in the diaphragm, stomach sliding in and out, never caused a problem, then all of a sudden it's a problem, and then now they're sick. That's wild.
He was fairly small too. He was only like maybe
20.
kids.
Yeah, so it would make sense though in that scenario that signalman wouldn't match your classical, right? Because it's the hernia that's causing the problem. It's not whatever's going on with these dogs. That's wild. But yeah, it's one of the indications for repairing a diaphragmatic hernia is to prevent gastric bloat and volvulus. Yeah, I've seen bloat, like just gastric distension, but never that before. Thank you for that. That's
Yeah,
cool.
I was like,
Wow.
I'm going to this. I'm happy to have this
Wow.
X-ray.
So I assume that they reduced it, pexied, and repaired the hernia.
Unfortunately, they did not move forward with
Sad
treatment.
days.
And as soon as I took that X-ray, I was like, I need a sentinel CRI right now. Right now, I don't care what we're doing. I will pay for this out of my pocket. This dog is not going to be any more pain. I can't do it.
Yeah.
So they did move forward with euthanasia.
They did euthanize, yeah.
But then like afterwards, they told me the history. They were like trying to get into an ER. They kept telling them, oh, it's going to be 8 hours wait, 8 hours wait. Like, don't come in here, go somewhere else.
Mhm.
And they just felt very lost. And when they came in and we finally gave them an answer, they were like relieved a little bit that they got the answer, but also very, very sad about that situation.
Yeah.
It was like, I'm so happy you brought him in for this reason. I'm glad we were able to get you answers, but that's the most insane
Yeah.
you have ever seen in my life.
Yeah.
And again, just an
So-
overnight ER shift.
Not to plug vet triage.
Yeah, yeah, no, I think that's super dope.
Well,
Like, that's
I'll
really
give you
cool.
my card and then
Yeah.
feel free.
Yeah.
I saw other hands, other calls.
Pick one.
Yeah, oh, sure.
I would love to. This is such a cool thing.
Thank you. Yeah, it helps give people peace of mind. And actually, what's yes,
Yeah.
yeah.
Are you hiring?
Yeah, should we email?
Yeah.
Yeah.
Yeah, he's a Colombiano.
Thank you. Yeah, of course. This is one more thing. Yeah, and the good thing, of course, because you can argue, well, what if vet triage says it's an emergency and they can't fit the minutes, 8-hour wait or whatever it is. Usually I find that because we call them in on behalf of the owner, we can usually push it. We've seen the dog on video, it's overtly unstable, we think it might be this. You guys are closest to them geographically, will you guys see them? And that typically will help them, because we work in very remote areas where there's like no option. So,
Yeah,
Yes.
RER, with referral, they get it a lot faster. Than
yeah. So that's one of the benefits. Or for the most part, over 80% won't have to go in because it's not an emergency. You can calm down and call your vet. Yes.
So when you get in, is there ever any question about how to detours? Like, have you ever been in there and you're like, I don't know which way this is tours? Or
Oh,
is it
yeah.
pretty obvious?
So the question is, whenever you've gone in there, have you ever looked at it and said, I don't even know which way to detour this thing? Absolutely. Oh, absolutely. If you have a hemoabdomen because of the spleen, you have all this omentum wrapped in there, 100%. So I try to start with the basic anatomy. First, I have my assistant, again, the technician, pass an orogastric tube. That really helps a lot. And if they are able to get through before I can even detours, I at least have some sort of fixation point now. Secondly, I'm looking for pylorus. That's what I'm looking for. Because the other part of the stomach, the fundus and whatever else, it's a big floppy mess. But the pylorus is going to be the same shape, a firm tube. So I'll follow the duodenum up, right? The descending duodenum, cranial flexure, and then hopefully you can grab pylorus there. Or I'm just rummaging through, and then once I feel what I think is pylorus, I'm going to detour. I'm going to push. So I'm on the right side of the dog, right? So head's over here, tail over here. I'm pushing down the stomach and
pulling the pylorus up, and then hopefully you hear that gurgling sound, and whatever. So that's the goal. Now, let's say it's one of those rare ones where it tours the other way. Yeah, because now what you're doing is you're making it worse, and but you'll see it's getting worse. Like things are getting more tangled, and you're like, what's going on here? So you have to think that it could towards the other way, but usually not the case. So yeah, I mean, now often the pylorus is
What, clockwise?
uh-oh,
Yes.
clockwise. Yeah.
Then you're
Yeah.
unwinding
Yeah, it
out.
goes.
Yes.
Yeah, pylorus is over this way.
Yeah. Usually the pylorus is like underneath, so I'm like grabbing like this, and like, oh, there it is, and then pushing it on the stomach, and then hopefully it'll undo itself. But yes, absolutely, it can be a mess with that. Yeah. Yes.
Two questions.
Mhm.
When you're pressing all gastric tube, do you have a preference of doing it intra-op versus pre-op?
So preference for orogastric tube placement pre-op versus intra-op depends on my staff and how quickly we're trying to work. If we're waiting on stuff, then pre-op. Usually, because we're moving quickly, it's going to be intra-op for me.
And then, do you have a preference of like induction medications or pain medications?
Oh, questions for, or preference rather for induction or analgesia? My technicians. Horrible. I know. I don't have to do any of those calculations. I know post-op, I'm usually going with hydromorphone, maybe buprenorphine, just depending on whatever I feel like that day. I'm not really doing CRIs, like fentanyl CRIs or whatever, MLK or whatever it is. But for induction, I imagine it's like hydrovalium, propofol induced. That's my guess, but I'm going to defer to the wisdom of my team for that one. Yeah.
And you like buprenorphine as a?
I like buprenorphine, yeah. How many folks here use hydro post-op?
We do, but we're having a hard time getting it
Oh.
backordered now.
So, okay. And how many use buprenorphine post-op?
That's my second go-to.
Second go-to.
I don't have hydro.
Yeah.
And use it for large stomachs?
Yeah. Yeah.
I've had some of you guys tell me only for cats and small dogs.
Because of price, smaller animals are cheaper.
I'm gonna say price because of like analgesia.
I was told ceiling effect, like that you only get so much pain control, and then if you add more, all you get is more sedation.
That's exactly what similar works.
We use hydro most often. That's the one we're going with. Yeah. Yes.
If you're gonna do this kind of surgery, how are you gonna approach it? So you're gonna go ahead and try to fix the GDP, get it out? Well, I never encountered something like that.
Oh, the one in her X-ray? Oh, yeah. So because I haven't either, but but I have repaired plenty of diaphragmatic hernias, and so the first goal is to try and carefully retract everything from the diaphragm into the abdomen. You have to be very careful because if it's a chronic hernia, like with a congenital one, there's going to be adhesions. Those adhesions could be intra-abdominal or intrathoracic, and so you don't want to pull something too hard and tear something. So you want to retract all the organs back into the abdomen, do an abdominal exploratory. Obviously, these dogs are going to be on a ventilator because they're not going to be able to have the diaphragm to help with respiration, so they're on a ventilator. And of course, once you do that, now they have a pneumothorax, so that has to be dealt with. So retract all the organs, do your abdominal exploratory, and resect intestines or splenectomy, whatever you have to do, whatever you got to fix. Liver lobectomy, all these are possible, or nothing. Everything looks good and it's just a hernia. And then you have to repair the hernia. Usually, when you repair them, I'm going to use non-absorbable suture, typically nylon or Prolene. I'm going to use, even though they don't have like the best They have very, very low drag and their knot strength is not that great, but I want permanent because you're talking about a congenital defect where the edges of it are scarred. And I don't really have the luxury. You're supposed to debride the edges or resect them. If you're working with a large defect like that, I'm gonna have a hard time even opposing them without using like mesh or something weird, I don't know, whatever, or not mesh, like a flap, which I haven't had to do, thankfully. I don't know how to do that stuff. But so I'm gonna oppose them. So because the edges are going to be not healthy edges, I'm going to use non-absorbable suture, simple continuous pattern, and then after that, place a chest tube, and then you're done. And aspirate them until negative pressure, and then they keep the chest tube post-op for probably like a day or two. The biggest problem with these cases, especially the ones that are not traumatic, is non-cardiogenic pulmonary edema. It's re-expansion pulmonary edema, because they've had months or years of pulmonary compression. And now you've relieved all that. That's when it sets up the inflammatory cascade of oxygen radicals and all that jazz, and and then they have severe pulmonary edema. It's terrible. So I played around with things like putting them on Lasix preoperatively, put them on CRI for Lasix, and all, because it's such a horrible, once it happens, it's hard to get them back from that. And it's not your fault, it's just the chronic compression. So that, the re-expansion pulmonary edema is a problem for the congenital. The traumatic ones, not so much. They got hit by a car, now they have a hernia. Yeah, those are not going to be the chronic ones. You know, that you can just fix them and that's it. Yeah. Oh, and then of course, if it's a GDV, I don't know if you PEXI them. You know, if it's a small breed dog or something, or a cat or whatever, I'm not sure I would. You know, if it's a large breed dog, deep chested, maybe. But we know the cause here, we would suspect, is the hernia, not just a random GDV, you know? But yeah, that's the only part of that, and I'm not sure what I would do. Yes, it was something.
What are your thoughts on like placing NG tubes and trying to stabilize surgery overnight?
Yeah.
That type of
Mm-hmm. So I had a surgeon I worked with who would do that, you know, mostly because they don't want to come in at night to cut the case. So like put an NG tube and you know, we'll do it tomorrow. I'm fine with it. I'm fine with it. If it's a logistical reason, sure. You know, whatever you have to do, right? If it's a wait for the owner decision, for them to commit to the surgery in their old Great Dane or not, sure, fine. But I'm a fan of it. You're going to need a nasogastric tube, ideally, that's going to go into the stomach, right? And not just past the distal esophageal sphincter, but actually in the lumen. So it's got to be a long tube. And if you're dealing with a Great Dane or something like that, most of these red rubbers are not that long. So that can be a limiting factor. But otherwise, if you have the appropriate size feeding tube, yeah, I'm fine with it. I'm also fine with it post-op. You know, if I'm worried about regurg or gastric distension post-op, whether it's in surgery or post-op in recovery, then an NG tube is great. It allows you to decompress the stomach, and then once that's resolved, if they need to be fed through the feeding tube, you already have it in there, and you can start trickle feeding them through that. Mm-hmm.
Have you ever managed them medically? I guess not. I know you're a surgeon, so.
For GDVs?
Yeah, where you do place an NG tube and see if it contours itself.
No.
I've never done it, but I've heard.
Yeah. The recurrence rate is so high, it's like 80% plus that it's going to recur. No, but I also don't know the timeline for that recurrence. I imagine it's like within a day or something. I don't know, but no, I've not done that before. Has anybody done anything like that before?
I've had ones that spontaneously untours.
Yeah, spontaneously untours.
Yeah.
Yeah. And that's the thing. If I document a GDV and then while we're waiting for anesthesia or whatever, the dog is fine again, I'm still going to recommend surgery. I'm still going to say we should. And it's even better now. He's stable. You know? But I still recommend doing it because he's clearly prone to it. He, she. Yes?
Do you think doodles are high risk?
Doodles? So do I think doodles are high risk? I don't think so. The ones that I've seen are always the Labradors, the Great Danes, the German Shepherds. I don't know. Has anybody else seen yeah? Like, what kind of doodles specifically, or?
Just we have a ton of doodles.
Yeah.
There's like
The larger mixed doodles? Yeah.
like maybe
I mean, it would make sense to me that anything that's large breed, deep chested, and they usually are, right, would be predisposed to it. But whether there's like a genetic link there, like with the golden retrievers or whatever, I don't know. Yeah.
Dachshund ones.
You had a dachshund? Yeah. Yeah, I had a beagle, I had a cocker spaniel. I think I had a corgi. Yeah, random. I know.
Like, really, dude? Really?
Random, yeah. Yeah.
I've had a
A couple
couple of Rottweilers.
of Rottweilers.
Yeah, concurrent,
Yep.
but
That was my only small breed. Usually they're the biggies.
Yeah.
And then I've had a few Dobies too.
Doberman pinchers, yeah. Yeah, remember to talk about bomb older brands with a Doberman. Any other questions? Anything else? Yes?
How often do you leave away with a GDP necrosis more than 50% on the stomach?
Not very often at all. The question is, how often do I see gastric necrosis with GDVs? Not often at all. Honestly, I think my experience with gastric resections is like single digits. It's not a common scenario.
I've had quite a few GDPs with a lot of them. It may have been just because coincidence time-wise, but I either had to, because they're so much persistent, you have to.
Yeah.
There's a rare or small percent that I am able to do the procedure,
Yeah.
but a lot of times I see them a lot more cases.
Yeah, and those are ones you wonder, like, you know, if you did close that abdomen up and wait 2 days and go back, you know, pexium, and then wait 2 days and go back in, you wonder, right? But yeah, I don't have an answer. That's terrible. I think we did euthanize one on the table because of that reason. There's just too, you can't resect all of this. But yeah, that's unfortunate. But yeah, I don't know whether it's just like just numbers, but I maybe single digits for me. I've been lucky to not have seen that many of them. Maybe they don't make it to me. I don't know, but I don't see them. Yes.
And then kind of going off that, like if you experience gastric rupture either before even going in or you get in trocar or gastric
Mhm.
tube, do you essentially just try to resect as much of it and kind of close it up and treat it as a septic abdomen at that point?
Yeah, so what I would do in that situation is I would debride the edges. 'Cause effectively, if it's a rupture like that, I'm going to treat it ideally like a gastrotomy now. So I'm going to make sure that the edges are clean. So I'm going to remove whatever necrotic tissue is there, or if there's no necrotic tissue, it was just bad luck or whatever else. But I'm going to resect that tissue and then close it, 2-layer closure. The positive part of having a septic abdomen from a stomach leakage is that theoretically, because of the low pH, stomach is pretty sterile as opposed to small intestine or especially colon where it's not. So I think usually when I've seen a gastric, like foreign body in a septic abdomen, it's usually a chemical peritonitis, not necessarily a bacterial peritonitis for them. So probably better for the pet. Now, if it's a chronic thing, let's say it's a ton of fluid in there, or you can see the abdominal wall, the peritoneum is all inflamed and whatever else, then I can place a Jackson Pratt drain in there, a JP drain. And a lot of times septic abdomens are going to be super effusive, and they're going to make a ton of fluid. So I've actually put 2 JP drains, one for each gutter. And you know, so it's coming out like close to the inguinal region, and the technicians are measuring left and right side, and we're seeing what the trends are, and then a lot of times those dogs end up having hypoalbuminemia, hypoproteinemia, so you have to manage that. But anyway, so most of the time with the gastric perf, it's going to be probably chemical peritonitis more so than bacterial peritonitis, and you treat it the same way as anything else at that point. Yeah. Yes?
At that point, do you do any splash block antibiotics in there? Splash antibiotics in there?
In the abdomen? I don't. But the other talk we had somebody who for pyometra, she'll do like a Baytril splash, I guess, or lavage. And anyone else here do antibiotics in the abdomen? Yeah, I know. I've only done it once in a, what was it? Is it a pleural effusion case? To try and get the pleura to scar down with a terramycin or something. I don't remember, it was a while ago, but yeah, you can inject antibiotic into the thorax and shake the dog around, and it's supposed to adhere, or maybe it's for pneumothorax. I don't remember. It's not popular things. More old school. Anything else? All right, thanks everybody. Appreciate you. Thank you so much.
Couple of non-related GW questions.
Sure. Yeah. Well, for the spay, if I pull up the pyometra one, let's see if I have that here.
Because I'm just getting ready to get my end of year numbers from the different organizations.
Yeah.
So I'll have my denominator.
I don't have the overall, I have the individual ones.
I took a picture
Yeah.
of that. Okay.
It may be in the proceedings that I have, 'cause I don't know it offhand,
Okay.
yeah. But if I do though, that's probably only for spays. I don't know, I don't have any information for neuter complication.
Okay.
But also, I haven't done literature search for neuter either.
Okay.
Because
Because I went on PubMed and I was just having a hard time finding.
That's where I go to, so yeah, that's my
'Cause
go-to
I
for
saw
it.
crazy numbers anywhere from 3% to 25%. I'm like, holy shit,
Yeah.
25%.
But it depends how you define complication. If it's an incisional problem, sure, I can see a quarter of the animals having incision issues.
Yeah.
Because then even that has a wide spectrum, but it's
True.
just inflamed or is it
True.
dehisced?
True.
So it's- yeah.
Yeah, okay. And then, can I drive to Vegas and chat you sometime?
Oh, sure. I work from home though.
Oh, never
'Cause
mind.
I have
Okay.
my triage. Once in a while, if I do surgery at my friend's clinic, then I'll go in there. But that's like random and
Yeah.
kind of spontaneous. But
Okay,
yeah.
so it's hard to make it. Okay,
Yeah.
I just figured I'd ask.
I spend most of my time at home working vet triage.
Well, thank you, appreciate
You're
it.
very welcome. Thank you for everything.
Yeah.
Good to see you as well.
California guy now?
Las
or-
Vegas.
Oh, you're Las Vegas
Yeah,
now?
yeah.
Oh, so you're not working at the Duque anymore?
Nope. Nope. Yeah, I had a falling out with the partners. I didn't like how they were doing things. They didn't like how I was doing things. So we.
It's California style, you know?
Parted
it's
ways.
a whole different picture.
Yeah, yeah.
So I don't like partners.
It was so strange. Yeah, exactly. I mean, I have a business partner now, but he's not a veterinarian. He does the marketing and all that stuff. So I do my thing. He does his thing. But working with other veterinarians are a pain in the ass, especially with specialists. They're so.
Any partner in any business.
So annoying. Yeah, yeah.
It's a royal pain.
Yeah, it is. It's like being married. It's. I mean, marriage can be good, but you have a very intimate connection with them.
Yeah.
Yeah.
You deal with numbers, with work, with
Yeah.
hours,
Yeah.
with other people.
All of it. How to put out fires, how to handle issues. Yeah.
Yeah, that's what when I put this hospital, you know, that I have,
Mhm.
had 6 doctors and 10 employees. And every day was drama, and I was the only boss.
Oh my God! Wow.
So you know what I did? I started getting rid of everyone.
Yeah.
I got 5 people, and then the net increased more than having like
All those people.
a bunch of people in
Yeah.
the overhead, you know?
Yeah.
So it's crazy.
Yeah.
And stop any doctors that don't want to work.
It's a huge cultural problem that we have now. They want to get 6-figure salaries. They want to work 3 days a week, 4 days a week.
2 hours a day.
And the problem is, I think part of it, a big part of it is our fault for being the field for not educating them where their salary comes from. They don't know why. They don't know why you're asking them to work this many hours if they want $100,000 a year, right? They think they just get a salary, but they have to understand if they're going to get paid $100,000, they have to bring in $1 million, right?
Correct.
But no, we don't tell them that, and they don't know. Like I had to learn it over time, But yeah, they have no understanding of where their salary comes from.
Well, I actually learned all my numbers in